Hi guys, how's
Dr.
it
Thomas,
going?
good evening. Good afternoon to
I'm
you.
here.
Hi, Thomas.
Hello, Dr. Thomas.
Dr.
I hope
Thomas,
you
thank
can
you
hear
for
me
joining.
clearly.
Yes, we can hear
Yes.
you. Thank you for joining.
Sure.
So, Thomas, after introduction by Dr. Neeraj, Dr. Sinchana, then I will give presentation for about 25-30 minutes, and then I will invite you to give the presentation, and then at
Yeah.
the end we'll take up questions by the participants.
Great. Okay, so you
Right.
start, Uncle, and then
So
I will
I
present the case with CSU angioedema, right? As discussed.
yes,
Yeah.
absolutely, absolutely, perfect,
So
perfect.
I have about 20 slides, so I will also have 15 minutes roundabout.
Perfect.
Yeah.
Perfect. Should be great.
Sanjana, we can
Yes.
start.
Okay, sir. Good evening, everyone. I welcome you all to the Allergy Forum, episode 4, which is being organized by the IAP Allergy and Applied Immunology chapter every second Tuesday of every month. And this time we have a case discussion on angioedema. I welcome Dr. Upin Narayan Reddy, sir, Secretary of IAP Allergy and Applied Immunology chapter, to deliver a welcome address.
Good evening, everyone. I welcome all of you on behalf of IB Allergy Immunology chapter. So today is a very important topic. This is one of the painful for patients suffering. This is very important and the practical. The presenter, Dr. Ankur Kumar Jindal, is a clinical immunologist and a rheumatologist, Manipal Hospital, Bangalore. And many expert is Thomas from Berlin. I think it's very useful and practical for practicing pediatrician allergy specialist. So over to Madam.
Thank you, sir. We would like to right now just start with the session as sir told, we have two experts today in the case discussion forum. And I would like to introduce them. First of all, Dr. Ankur Jindal, who is actually specialized. He has done his DM in pediatric clinical immunology and rheumatology, and he's a consultant in the same field at Manipal Hospitals, Bangalore. He was a former associate professor at the esteemed PGI Chandigarh Institute, and he has done a lot of research in angioedema, urticaria, PID, and his areas of interest, which are the same. And he has around 220 publications to his credit in national and international journals. He has done a lot of good work in the field of angioedema and has a lot of clinical experience as a great academician and clinician. I welcome you, Dr. Ankul Jindal, to this forum, and we are very fortunate to have you on this platform. We also have Dr. Thomas Buttigieg, who is also going to give his insights into this topic. And he is from the Institute of Allergology at Charité University, Berlin. He is a great academician and clinician as well. He has been the clinical investigator in the group of Professor Maurice Maurer in several clinical trials related to chronic spontaneous urticaria, angioedema, mastocytosis. He is also the head of clinical trials at his institute, and he's done a lot of teaching activities. He's a co-head for angioedema research as well. He's a speaker at various congresses, and he has many publications to his credit in very famous journals. And we are very privileged to have you, Dr. Thomas, at this forum. I extend a warm welcome to both of you, and the forum is all open for this one case presentations and discussion. Thank you.
Thank you. It's my pleasure.
Okay, thank you, Dr. Sinchana and Dr. Neeraj sir and Dr. Reddy for giving us the opportunity today to talk to all of you about this subject, angioedema, which is not really often talked about in most forums in India. So I think this is a very unique subject. A very challenging subject which you will understand as we present it, but I think we'll try to make it as simple as possible. So me and Dr. Thomas, who is a colleague, who is a friend, a very good dear friend to me, and we will be taking up this subject try to make it as simple as possible. So once again, to the IAP Allergy Immunology chapter for giving us this opportunity, and we'll try to keep it case-based discussion today. And I would request everyone to post in your questions and comments in your chat box as and when you have it in your mind as we go through these presentations. So nothing to disclose in relation to this presentation. I hope my slides are moving. Dr. Neeraj, Dr. Sinchana, anybody can confirm?
Yes, yes, yes.
Okay. And my voice is okay,
Perfect.
right?
Yes,
Okay.
perfect.
Perfect. So this is going to be the overview of my presentation. I will be talking briefly about definition and classification of angioedema, how to differentiate allergic and hereditary angioedema. Like this is a more general term that I've been using, allergic angioedema, but the more technical term is mast cell mediated angioedema, and hereditary angioedema falls into the category of bradykinin. So there are two main mechanisms. One is mast cell, and other one is bradykinin. So the mast cell, we in a more layman term, we call it as allergic angioedema, and the bradykinin mediated angioedema, the most common form of bradykinin mediated angioedema is hereditary angioedema. So while I'll be discussing about some of the differentiation between these two entities, because from a clinician point of view, this is very, very important. And then I'll be talking in detail about the clinical manifestation, diagnosis, and management of hereditary angioedema. And this will be entirely case-based. So once I finish, Dr. Thomas would take you through case scenarios of mast cell mediated angioedema with chronic spontaneous urticaria, the diagnosis, the management aspect of that group of disorder. So I'll give you a few case scenarios just to help you understand how these two group of disorders look like in a clinical practice. So this is a 6-year-old girl, and I saw this girl a couple of years ago. So she's been symptomatic for the past 2 months. She has these recurrent episodes of swelling. You can see her eye is swollen over here. Now these episodes are associated with these urticaria kind of lesions, as you can see over the trunk, and these are also associated with the intense itching. What is very characteristic is that these swelling episode would appear over a few minutes. I mean, they would appear very, very suddenly, and these episodes would disappear within 10 to 12 hours, maximum 24 hours. And they tend to respond very good to antihistamines that she was prescribed. And there was no suggestive similar illness in any of the family members. A very similar patient. No, this is an 8-year-old girl. You can see these swelling episodes over the eyes, recurrent swelling episodes. And again, these were associated with urticaria, itching. They were coming very suddenly and would disappear within a span of 24 hours. And they would respond very well to antihistamines, and there will be no family member affected with the similar illness. So this is mast cell mediated angioedema. Clinically, it's very easy to make a diagnosis of mast cell mediated angioedema in these cases just by looking at this particular clinical profile. Now look at this case. This is a 12-year-old boy who has been symptomatic for the past 2 years. Now this is a very long history. And this boy also has recurrent episode of swelling. And as you can see in this photograph over here, the lip is swollen. So these episodes are not associated with any urticaria, not associated with any itching. What happens to these swelling episodes? These swelling episodes evolve gradually over 6 to 8 hours, and they persist for a few days and disappear totally in about a period of 3 to 5 days. And these swelling episodes are not responding to antihistamines. What is also very characteristic in this boy is this boy has a significant family history of similar illnesses occurring in his brother, his father, his paternal aunt, and his grandmother. Now, with this clinical background, there is no doubt that this is a case of hereditary angioedema, and also confirmed by doing the laboratory tests C4 and C1 inhibitor levels. And of course, we also did genetic testing in this case, which is not really mandatory to diagnose a case of hereditary angioedema. But yes, this was also done. So this is clear-cut hereditary angioedema. I'll show you another case. This is a 7-year-old girl. I saw this girl a couple of months ago. She's a resident of Gujarat, and she's been symptomatic since the age of 3.5 years. Now she has what she had when she presented to me was she was having just recurrent episodes of vomiting and pain abdomen. She never had any episodes of peripheral swelling. She only had episodes of vomiting and pain abdomen, and three such episodes so far. And every time, at least once, she's been treated as subacute intestinal obstruction. And each of these episodes would last for 2 to 3 days. Now, these episodes were associated with intense pain abdomen. No urticaria and no itching were noticed. And as I mentioned, she had no peripheral swelling episodes so far in last 3.5 years since she has been symptomatic. But what was very, very characteristic in her was the family history. Her mother, who is 39-year-old at present, she has been symptomatic since the age of 15 years. Now, what was happening to her between the age of 15 years and 30 years, for those 15 years, she used to have only episodes of vomiting and pain abdomen. And at some point of time, she also underwent an ultrasound, which was showing diffusely edematous thickening of the walls of jejunal loops and mild ascites. Now, at some point of time, she was also treated with sulfasalazine, thinking that this is inflammatory bowel disease. Till to the age of 30 years, she had only these episodes and no episodes of peripheral swelling. But after the age of 30 years, she started developing peripheral swelling episodes. You can see over the feet and all the lips. And then she was diagnosed to have hereditary angioedema. And of course, the girl, because mother was known to be diagnosed to have hereditary angioedema, it was relatively easy for her to diagnose as hereditary angioedema. So both of these are hereditary angioedema. What I mean to say that patients with hereditary angioedema can sometimes have only abdominal symptoms for a few years before they start develop any peripheral episodes as well. Now, this is one more case, a very unusual case, a very difficult case. So I saw this case in March this year. This is a 13-year-old boy who was symptomatic for the past 6 months. Now, he used to have recurrent episodes of angioedema. As you can see in one of the photographs, his eye is swollen. Now, these episodes were predominantly over face, but also were affecting the hands. Mostly, they would be noticed in the early morning hours. So when he gets up, he would notice swelling episodes, and these swelling episodes would then gradually evolve over 24 hours, and the total duration of the episode was about 3 days. He also noticed some abdominal symptoms. Now, these episodes were not associated with any itching, and no urticaria was noticed. However, mother said that probably these episodes are triggered by stress. This was just a question mark because we were not very sure. No prodromal symptoms were reported with these episodes, and there was no similar family history. And mother reported plus minus response to antihistamines and corticosteroids that he was given. So when we saw this boy, we knew that this could fall into any of the categories. He has symptoms, some of the symptoms which look like hereditary angioedema, some of the symptoms that look like mast cell mediated or allergic angioedema. So just a working diagnosis of angioedema without urticaria was made. And, these cases would require investigations. So when we investigated this patient, his C4 was just borderline normal. So you can see the normal range is 14.9 to 44.5, and his C4 is 15.6. His C1 inhibitor level, instead of being low, it is actually high. And I'll come to this point later in my presentation. Now, when we saw his C1 inhibitor report, which was so high, we realized that something is wrong and we need to do his genetic test. And we did his genetic test. I received this report just 1 week ago, and he has this mutation in the SERPING1 gene, which typically causes type 2 hereditary angioedema, and I'll come to that during my presentation. So this is the last case before I go to discussion of hereditary angioedema. So this is a 44-year-old female who is resident of Chandigarh, and she had these episodes, as you can see in these photographs. So these episodes started at the age of 44 years, and she had 4 episodes so far in last 3 months of the history that she came with. And when she came with these facial puffiness. She also had difficulty in breathing. So she already had developed laryngeal edema. Now, what is very characters, and these episodes are not associated with any urticaria and any episode of itching. Now, what is different in this case as compared to the cases that I showed you of hereditary angioedema, that this lady has started developing symptom after the age of 40, and she has low C4 level, she has low C1 esterase inhibitor level, but this is not hereditary angioedema. This is what we call it as acquired angioedema, which typically behaves like hereditary angioedema, but has symptom onset in the 4th and 5th decade of life. So what is angioedema? Angioedema is a localized swelling, as you've seen in a lot of cases and some of the photographs, as you can see over here. And this is a swelling episode, edema of the subcutaneous and or submucosal tissue, which is caused by increased leakage of plasma from capillaries located in the deep layers of the skin and mucosa. Now, urticaria is a superficial kind of swelling. Angioedema is a more deeper swelling in the skin and the mucosa. It's typically non-inflammatory, that you don't see any signs of inflammation on the swelling episode, unlike cellulitis. And these episodes are self-limiting or episodic. So these will come, will disappear, will come again. So you treat these episodes, or you do not treat these episodes. The rule is that they have to be episodic. They will come, disappear, then will come again. So that is the classical nature of an angioedema episode. So if a swelling episode is persisting for 2, 3, 4 weeks, this is very unlikely to be an episode of angioedema. You need to think of any other differential in that case. So there are several differential diagnoses, and inflammatory edema, as you can see in cases of vasculitis, dermatomyositis, sometimes nephrotic syndrome can be confused with angioedema. We've seen a couple of cases wherein granulomatous cheilitis, orofacial granulomatosis, wherein the swelling will persist for several months. That has sometimes been confused with angioedema. And then there are a few more differential diagnoses that need to be considered when your patient doesn't fulfill this typical definition of angioedema. So this is a broad classification, and mast cell mediated angioedema is often associated with chronic spontaneous urticaria, but in 10% of the cases, it may not be associated with chronic spontaneous urticaria. And I would leave this entity to Dr. Thomas. He will discuss this in detail. Bradykinin mediated angioedema, we'll talk about hereditary angioedema in detail, but acquired C1 esterase inhibitor deficiency or acquired angioedema is typically seen in association with lymphoproliferative disorders or autoimmunity. And over here, the classical presentation is that they have symptoms onset in the 4th and 5th decade of life. We don't see this entity in children. If you go to a cardiology practice, we're using AC inhibitor for angioedema, for hypertension. About 1% of all patients who are using AC inhibitor would develop angioedema, which would look like bradykinin mediated angioedema. So whenever you have a patient, especially in the older age group, who presents with angioedema for the first time, it's very important to take history of use of AC inhibitors, because most often when you remove AC inhibitor from the treatment regime, the angioedema disappears in these cases. And this is the most recent classification of angioedema. And as you can see, this has been developed by Dr. Thomas and his group, Dr. Aaron from Israel, Dr. Thomas from Germany, and many other colleagues over here. What this classification tries to show you is that the new classification, new way of looking at angioedema is through endotypes. And over here, other than mast cell mediated, bradykinin mediated, there are other mechanisms such as vascular endothelium dysfunction, drug-induced mechanisms, which are being explored. And the angioedema has now been grouped into 5 different endotypes. I will not go into details of this, but you should go through this publication. If you're interested in angioedema, there are standard terminologies that have been described or defined for the angioedema types and many other acronyms used in this classification. So, in the coming years, we'll be using these standard terminologies in all forms of publications. So how does a clinician differentiate whether this is a mast cell mediated angioedema or a bradykinin mediated angioedema? As I've shown you through the case scenarios, I'll highlight this once again. These are 4 very important points. If you see urticaria, if you see pruritus, this is very, very likely to be mast cell mediated or allergic angioedema. And a swelling which is coming very, very rapidly and usually disappearing within 24 hours, maximum 48 hours, is very likely to be allergic angioedema or mast cell-mediated angioedema. While bradykinin-mediated angioedema, typically swelling would appear slowly and would disappear in a few days, 3 to 5 days typically, and you don't see urticaria and pruritus into that. You over here you see this typical untreated attack of hereditary angioedema. So the symptoms start, they evolve gradually, stay for some time, and then they disappear in 3 to 5 days. On the other hand, mast cell mediated angioedema has a quick onset and quick recovery within 24 to maximum 48 hours in a few cases. The other important point over here is a family history. So if you see a family history which can be characteristic in HA in about 80 to 85% of cases, that's very common, and it's a very important clinical pointer. Over here, I haven't highlighted this point, but laryngeal edema is a very, very important point. And of course, the abdominal symptoms, severe abdominal symptoms and episodes of laryngeal edema, which leads to asphyxiation or which is leading to hoarseness of voice, you never see in patient with mast cell mediated angioedema, while this is a common presentation in patient with hereditary angioedema. So over here, on the left side of the screen, you see patient with allergic angioedema, urticaria, and on the right hand of the screen, you see patients with hereditary angioedema, bland kind of swelling. You almost never see urticaria in these patients, and this differentiation is entirely clinical in most cases. So apart from the other symptoms that I've just mentioned about the swelling episodes, abdominal symptoms are very, very common in patients with HAE. They can be sometime inadvertently mistaken as acute abdomen, maybe subjected to surgery. Over here, you can see how some of these patients can present. This is one of the case was reported by one of my colleague from Hong Kong. And over here, you can see this dilated, hugely distended abdomen, which was inadvertently subjected to surgery. And resection was done. Now this was an episode of hereditary angioedema, and later, a few years later, it was realized that this patient has HAE, and actually, the surgery was not really required in this case. So these episodes may sometimes be associated with nausea, vomiting, diarrhea, constipation, and sometimes acute, sometimes associated with abdominal distension as well. Laryngeal edema can happen in about approximately 50% patients, at least one episode during their life, and it can be fatal in about 30% of the cases. Now, this is what used to be in the past. Now, in the West, the fatality because of laryngeal edema in HAE has reduced very significantly. However, this continues to be a problem in many parts of the world, including India and many other Asian countries. So this is what I told you about, family history. It's an autosomal dominant condition. So, one of the parents or one of the grandparents will have a family history. And this is not very uncommon to see a family history of this kind, wherein when we diagnose a patient to have HAE, we realize that the mother also has HAE or the father has HAE and even grandparents have HAE. And this is the kind of family tree that we get to see, when we diagnose this case to have HAE. This is a family from eastern part of India, Odisha, and we realized that this family has lost 10 family members because of laryngeal edema, and there are at least 13 family members who are still suffering with this disease, and they have not yet been diagnosed to have HAE. So HAE has been classified into type 1, type 2, and type 3. Type 3, we don't use the term type 3 HAE now. We call it as normal C1 inhibitor HAE, wherein the C1 inhibitor level and function are normal. Type 1 is most common, wherein you see low C4 level and low C1 inhibitor levels. Type 2, as I showed you in one of the cases, will have a low C4 level, but the C1 inhibitor level, instead of being low, it is either normal or most often it is going to be high. And that's a clue. Like if you see a low C4 and a high C1 inhibitor level, this is the indirect marker that you're dealing with probably a type 2 hereditary angioedema. This is because of dysfunctional C1 inhibitor protein. So if you do the function of the C1 inhibitor, it will be abnormal in these cases. So how common is this disease in our country? So based on the global prevalence, we expect that there are at least 27,000 patients with this disease in India at present. However, we haven't yet been able to diagnose more than 700 patients so far. So there is a lot of work that needs to be done. And I think the allergy specialty is one wherein these patients can commonly present with. So you have to find out which of these cases is not urticaria or mast cell mediated angioedema, and which is actually bradykinin-mediated angioedema or hereditary angioedema. So once you suspect, diagnosis of hereditary angioedema is not very difficult. So, once you suspect, all you need to do a C4 level and a C1 inhibitor level to nearly confirm the diagnosis of HAE. Doing C1 inhibitor function is still a challenge in our country, and we don't really struggle with C1 inhibitor function because it's not easily available in most centers, and it is not easy to access this test. So what we rely on is C4 and C1 inhibitor level. And if you do these two tests, in most cases, you will be able to diagnose hereditary angioedema. C4 has a sensitivity of about 80%. So when C4 is tested during an acute episode, the sensitivity increases. As I showed you in one of the cases, that a borderline low C4 can also give you a very, very important clue. It looks within the normal range, but it is towards the lower range of the normal. And then it itself is a very important diagnostic clue in a patient wherein you are clinically suspecting, strongly suspecting hereditary angioedema. So when I was in PGI Chandigarh till about 3 months ago, so we had been able to diagnose more than 300 patients with HAE over a period of few years. So this all started with 20 patients in 2019, and then we started collecting these cases, and with the help of the A-Care Network, the HAE International, and many other organizations who helped in collecting all these cases. So what we tried to look, and we analyzed the clinical profile of these patients. So we analyzed about 235 patients out of this cohort. What we realized that how are we different from rest of the world? What we realized that in India probably we don't see so much of abdominal symptoms, about 66% in this cohort, as compared to Western population, wherein this is seen in more than 90% of the cases. On the other hand, we see a lot of laryngeal episodes and a lot of facial episodes as compared to what has been reported in the West. What I want to show you over here is, with whatever treatment options are available with us, we have been able to give them a good quality of life. In this, the median frequency at presentation in this was 12, and at the time of presentation, and it reduced to 4 with whatever treatment we gave. We've also been able to diagnose a few asymptomatic patients just by doing family screening, and we have at least identified 28 families who have reported death of family members due to laryngeal edema, and none of these patients were diagnosed to have HAE at the time of diagnosis. So coming back to the basic principles, how you manage this disorder, and I think take about 5 to 10 more minutes to finish talking about the management of HAE. I'll give a very brief idea and give you some case scenarios how we manage these patients. So this is just a pathophysiology slide just to make you understand, so that you can understand management better. So everything starts with activation of factor 12, by contact system activation, which activates prekallikrein to kallikrein, and then kallikrein cleaves high molecular weight kininogen to produce bradykinin, and this bradykinin is the culprit in patient with hereditary angioedema. And this over here, as you can see, it causes vasodilatation, leakage from the capillaries, and this is the one that causes angioedema. And what happens in patient with hereditary angioedema, that this production of bradykinin is controlled by a protein called C1 inhibitor protein. As you can see, at so many steps, C1 inhibitor protein is controlling the production of bradykinin, and when C1 inhibitor protein is deficient, bradykinin production goes up, and that is the main pathophysiology. So what we can do, we can replace C1 inhibitor protein. That's one form of treatment. We can inhibit kallikrein by giving drugs. We can inhibit bradykinin. Unfortunately, these drugs are not available in India at present, but we have tranexamic acid, which blocks conversion of plasminogen to plasmin, and to some extent decreases the production of bradykinin. So these are the drugs which are available for management of HAE in India. The ones that have been highlighted in yellow are the ones that we use, and the ones that have been highlighted in white are not available in India at present. So the principles are on demand. When they have episode, we give them treatment, long-term prophylaxis to prevent the episode, and short-term prophylaxis during such periods such as procedures, dental procedure, or any major surgery, wherein we can use these drugs to prevent an episode of angioedema during those situations. So I'll give you a few case scenarios to make you understand how we manage these disorders. So this is a 14-year-old boy. I showed you this case previously. This is a patient who has been diagnosed to have HAE and has now presented with an acute episode of laryngeal edema. So as I said, this has already been diagnosed to have HAE. He has a good family history. And now what you do in these cases? Now this patient has been diagnosed to have HAE and has presented with acute episode of laryngeal edema. So there are several options. You can give fresh frozen plasma. Most often, these patients end up receiving hydrocortisone and epinephrine. What I want to highlight over here is hydrocortisone and epinephrine, even tranexamic acid and stanozolol, is not the treatment of an acute episode of laryngeal edema or any acute episode of angioedema in patient with HAE. These patients need plasma-derived C1 inhibitor concentrate. And when they develop laryngeal edema, we have to give them a slightly higher dose of 20 unit per kg. Fresh frozen plasma is another option, but we are now using plasma-derived C1 inhibitor concentrate more and more often. Now, this boy, when he came with that complaint, this was the year 2021 when we did not have access to C1 inhibitor concentrate. And this is what we did. We gave him fresh frozen plasma, almost continuous infusion for the next 48 to 72 hours. And that is how we could salvage him from this particular condition. And this is year 2023. Now, what we do is we give them plasma-derived C1 inhibitor concentrate, and within a few hours they respond beautifully to plasma-derived C1 inhibitor concentrate. So that is the drug of choice for on-demand treatment now for us. So these are some of the guidelines, some of the consensus recommendations in the Indian context. So each patient need individualized treatment. Ideally, all episodes of angioedema should be treated. However, considering that we do not have such good availability and access to C1 inhibitor concentrate, at least at present, we recommend at least all laryngeal episodes and tongue episodes and all abdominal attacks must be treated with plasma-derived C1 inhibitor concentrate. And what we are really stressing nowadays is it should be self-administered at home, either by themselves or by a nearby healthcare practitioner. FFP is just an alternative, but there are several challenges with the use of fresh frozen plasma, and we are moving away from the use of fresh frozen plasma as much as possible. The dose is 10 to 20 unit per kg. So if you have a laryngeal episode, try to use a higher dose of 20 unit per kg or 1000 unit. As I said, the focus now is to advise these patients to take plasma-derived C1 inhibitor concentrate at home by self-administration. So this slide shows the challenges between use of fresh frozen, differences between use of fresh frozen plasma and C1 inhibitor concentrate. And this is a practical scenario that we face every single day. Whenever there is a patient who goes to emergency room for getting fresh frozen plasma, he develops an acute episode, goes to hospital, which may take 2 to 6 hours. That hospital has to have access to blood bank. The physician has to understand, and invariably that physician will give adrenaline, steroid, and epinephrine despite the patient having that prescription. Now, during this process, somehow they take a decision to give FFP and administration of FFP. This may take about 4 to 6 hours. This is a long process that patients have to follow if they want to take fresh frozen plasma. However, if you want to take C1 inhibitor concentrate, you develop an acute episode, you decide to take C1 inhibitor concentrate, and this process can maximum take about 15 to 30 minutes, not more than that. So the window of opportunity to use on-demand treatment is this, and this window of opportunity can never be achieved with fresh frozen plasma, can only be achieved with C1 inhibitor concentrate. So FFP is less effective, it has a slow effect, it of course has side effects, and there is an issue of volume overload. Plasma-derived C1 inhibitor concentrate is much more effective than fresh frozen plasma. It is very quick to act, practically no side effects. However, cost is the slightest of factor, but I mean, this is something which is being accepted by patient much more in India right now. I'll show you a couple of more cases. This is a 23-year-old female who was diagnosed to have HAE based on low C4 and low C1 inhibitor level. She was on long-term prophylaxis with tranexamic acid and stanozolol, and because she decided to have a pregnancy, we had to stop tranexamic acid and stanozolol. Now, during pregnancy, she had these frequent episodes of edema, as you can see over here. And the best drug to be used during pregnancy is only plasma-derived C1 inhibitor concentrate. And she was given frequent injections of plasma-derived C1 inhibitor concentrate during these episodes. Now, this is a young boy, a 4-year-old boy who's been symptomatic for the past 2 years, and very characteristic symptom of HAE. And also family history. Over here, you can see the father of this child has lost all 4 of his siblings because of this disease. So he was diagnosed to have HAE. Now what you do? This patient has very frequent episodes, at least 1 episode every month. So for long-term prophylaxis, we put these patients on tranexamic acid and we add stanozolol to these cases, or danazol to these cases if there is no adequate response. We can also put them on long-term prophylaxis with plasma-derived C1 inhibitor concentrate. So these are some of the recommendations for long-term prophylaxis in Indian context. We can use attenuated androgens or tranexamic acid or a combination of the two. We can also use intravenous plasma-derived C1 inhibitor concentrate in certain settings. Especially in pregnancy, especially in young children, wherein the side effect of these drugs are a real concern. And these are the doses that we use. We try to give minimum possible dose of attenuated androgen. Tranexamic acid, on the other hand, is very, very safe. So we've seen side effects with the use of androgens, especially in females, menstrual irregularities, hirsutism, as you can see in this photograph, and hoarseness of voice, hypertension, weight gain. But most of these side effects in our experience are manageable. They are reversible when you minimize the dose of the drug or you temporarily discontinue the medication. Tranexamic acid, in our experience, has been found to be very, very safe without much side effects. The other measures that we need to advise to these patients is never use AC inhibitors, never use estrogen in these patients, avoid triggers as much as possible, and it's very important to participate in the patient support groups. Last case, this is an 8-year-old girl who is resident of Chhattisgarh, and she has been diagnosed to have HAE. She's on prophylaxis with stanozolol and tranexamic acid. Now she wants to get a dental extraction done under general anesthesia. Now, dental extraction is a very dangerous procedure in patient with HAE. It can lead to a very rapidly evolving laryngeal edema. So what we need to do is we need to give them preferably plasma-derived C1 inhibitor concentrate just before the procedure, and we can repeat C1 inhibitor concentrate if required after the procedure if they develop a swelling episode. FFP is an alternative, but plasma-derived C1 inhibitor concentrate is the best possible form of short-term prophylaxis for these patients. So this is the recommendation for short-term prophylaxis. Intravenous plasma-derived C1 inhibitor concentrate 10 to 20 unit per kg just before the procedure, and it must be given for all dental extraction, all endotracheal intubation, endoscopy or bronchoscopy, but all even minor surgeries would require a backup of intravenous plasma-derived C1 inhibitor concentrate. So no procedure should be done without having a backup of plasma-derived C1 inhibitor concentrate. So this is my last slide. HAE is characterized by recurrent episodes of non-HE swelling. Urticaria is not a feature. It often remains undiagnosed. We need to have a very high index of suspicion. Laryngeal edema is a potentially life-threatening manifestation. Suspicion is the key. Diagnosis is not difficult in patients with HAE. These tests are now easily available. C4 is a very simple screening test. C1 inhibitor level is also easily available, and that nearly confirms the diagnosis. And plasma-derived C1 inhibitor concentrate is now the drug of choice. So with this, I wish to end, and feel free to connect. If you wish to connect even after this webinar. And I hand over to Thomas to present his talk. Over to you, Thomas.
Thank you very much, Ankur. I will. I hope you can hear and see my slides.
Yes, Thomas, we can hear you.
Perfect. So I'm happy to give you a short presentation, a case discussion on angioedema, some classical cases I see in my clinic here in Berlin. What you see here, and Ankur has seen it already, is the Institute of Allergology in Berlin, a research institute with focus on recurrent angioedema and other mast cell-mediated diseases, also including rare diseases like hereditary angioedema. But in this presentation, I would like to present to you a classical case I often see in clinics. So imagine there is coming this 58-year-old man. In this case, he is a Caucasian, so a typical German, as you can see here. And he complains about recurrent angioedema since 2 years. And these swellings usually occur on the tongues, lips, and genitals. And he reports about 4 to 5 angioedema attacks a month. And when you ask the patient when the angioedema attacks usually start to commence, he says, well, they usually start in the early morning hours or late at night. And then they develop very slowly. But after 2 hours or so, they have the swelling as maximum. And he was already advised by his GP to take cetirizine, so an antihistamine once daily, but this had no effect. And the patient, when we ask the patient says, well, there are no hives, no wheals. The patient has some comorbidities, which is hypertension, and he's also a bit obese, maybe a higher body mass index, but he is taking no medication which can be related to angioedema. So he's not taking any NSAIDs, non-steroidal antirheumatic drugs, and also no ACE inhibitors. So amlodipine is the treatment he takes. And he has also negative family history for recurrent angioedema. And the patients also usually come to our clinics already with normal or with certain blood levels. And what you can see here is that the values we are mostly interested in were normal. So look at C4, C1 inhibitor level, and we are also in the happy situation to measure C1 inhibitor function in our clinic. Were all normal, but also C1q and an immunofixation was done, which was all within the normal range. And he had also no findings in the differential blood count and tryptase levels. So everything was normal. So what is actually now the next diagnostic step? And this, what you can see on the left-hand side, is a very recently published, let's say, algorithm how to approach patients with recurrent angioedema, which has been published by the US American group. So the first step, of course, is you need to be sure that this is angioedema. Anko already showed you what angioedema looks like and what the typical nature of angioedema is. But the next step would be also to ask the patient if the patient has some wheals or hives, and the patient as I said already, has no hives or wheals. And C4, C1 inhibitor levels were all normal. So HAE due to C1 inhibitor deficiency or acquired C1 inhibitor deficiency, as Dr. Anko already discussed about, has been automatically excluded now. So the next step is also ask for medication. As you can see, the patient only takes amlodipine, so there's no medication, no drug suspected to be the reason, the cause for recurrent angioedema this patient is taken. So ACE inhibitors, dipeptidyl peptidase inhibitors, neprilysin inhibitors, tissue plasminogen activators, and NSAIDs, they are all not taken by the patient. So medication-induced angioedema, drug-induced angioedema is also excluded. Now, the next step would be now to look for response actually to treatment. And there's also no family history, as I said. So before you do this, actually, to think about rare causes of recurrent angioedema, the next step should be actually to set this patient on treatment. So, and you use usually the guideline for chronic urticaria to treat this patient. So as you see, the patient failed already in standard dose antihistamines using cetirizine. So the next recommendation step is to up dose to the 4-fold dose according to the urticaria guideline. And what happened in this patient, this is what you can see, the daily intake of the standard dose of cetirizine, 1 tablet a day. The patient continued to have 4 to 5 angioedema attacks over the past 3 months. And then you started the antihistamine to the 4-fold dose, and the patient came back after 2 or 3 months. And again, there was actually no response in this patient to 4-fold antihistamines. And this is really a tricky situation as a clinician, what actually to do next. And if you look in this algorithm, the next step would be, according to the global urticaria guideline, to introduce omalizumab, which is an anti-IgE monoclonal antibody licensed for the treatment of chronic spontaneous urticaria. And this is usually the next step we do if there are no other hints for HAE or for rare types of HAE in this patient. And look what happened then. We introduced omalizumab in this patient in 4 weekly intervals, and this patient was symptom-free right from the first dose of the first injection of omalizumab. So omalizumab worked, and this was not only a therapeutic step, but also at the same time a diagnostic step, because this treatment unravels also mast cell-mediated angioedema. So when you see a patient with recurrent angioedema, the most frequent reason and cause for this type of for angioedema is mast cell-mediated angioedema, especially together with urticaria. So patients may present with wheals and angioedema or exclusively angioedema, which is very common in the population worldwide. 1 in 100 patients or people suffer from chronic urticaria. And so think about the horse first. There's a German sentence one could say, you know, when you see patients like this, think about which is most common, which is mast cell-mediated angioedema. And and then the next step would be to think about rare causes of angioedema like HAE due to C1 inhibitor deficiency. There are also these even more rare types of HAE with normal C1 inhibitor, which is colored zebra here. And when it comes very, very rare, think about the unicorn, where the cause of HAE is unknown. So we only have a couple of patients where we could not find out the cause of recurrent angioedema, so which is really, really, really rare. Well, why do I call this urticaria? Well, it has to do with some nomenclature and definition. You know, when you look into the guideline for urticaria, urticaria is defined as a condition characterized by the development of wheals, angioedema, or both. So theoretically, you have 3 groups of patients. So patients that never experienced angioedema so far, they only have wheals, hives. Then we have a big group of patients that have both wheals and angioedema, and a smaller group which exclusively develop a recurrent angioedema and never have seen wheals, hives in their life. And urticaria is defined actually by its duration of the disease. When urticaria, wheals, and/or angioedema happens without 6 weeks, on subsides within 6 weeks, it's by definition acute urticaria. When you have it longer than 6 weeks, it's by definition defined as chronic urticaria. And there are certain subtypes of chronic urticaria. The most common one is chronic spontaneous urticaria. So wheals and angioedema occur spontaneously. You cannot trigger it. So that just happens, you know, without any impact of the patient. But there are also these other types of chronic urticaria, which are called chronic inducible urticaria, which means that there always have to be a certain trigger and a definite trigger, like for example cold, or the sun, vibration, or exercise, or even stretching, like in the most common type of chronic inducible urticaria, we call it CINDU, the symptomatic dermographism. So as I told you about already, we have these 3 CSU phenotypes: wheals only, both wheals and angioedema only. I call it also urticaria because it's in the definition. But you know, there are some specialists who do not like this definition. They call it histaminergic angioedema or mast cell-mediated angioedema without urticaria. And these patients have exclusively angioedema. It's an ongoing discussion, and some more research is needed. But what I can tell you is, again, that most of the patients that have urticaria also experience angioedema, wheals and angioedema. So it really makes sense to ask patients if they have ever seen hive, a wheal, during the episode the patient has angioedema. Of course, patients also can have both HAE and urticaria. So they are 2 distinct diseases. But, you know, urticaria is much more common than HAE, as Dr. Anque has shown you. And you see here on this pie chart some investigation on 3,698 patients in the biggest registry for chronic urticaria cure, which has been developed by the Urticaria Centers of Excellence and Reference. And here you can see data from 5 continents and 47 centers, UCare centers, which is the partner of ACARE. So it really makes sense to ask your patients if they ever have had wheals. Usually wheals and angioedema, when the disease starts, occur at the same time. There are some patients that tell you, okay, wheals first occurred before angioedema came, but interestingly, there are also some patients, 8% of the patients, who said, well, angioedema was the first manifestation of the urticaria, and then wheals happened. But so it really makes sense. Have you ever seen something like this, like a wheel? So show it to the patients what you really mean, how a hive and a wheel look like, so that patients can confirm whether they had it or not. And this will help you with the diagnosis. And chronic spontaneous urticaria is, as I said, a very common disease, and it happens in the middle of life. Usually women are more often affected than men. 2 to 1 is the ratio, but you can see here, according to this analysis published in 2009 in Allergy, is that every age group can be affected, but mostly in the 40s, in the middle of life, and the best time of the life you have, you're affected by this really disturbing and disease which affects your quality of life. I and our team, using the data from the global registry, and that's why registries are very important, analyzed some data of patients that have recurrent mast cell-mediated angioedema with wheals and without wheals. And what you can see here on this table is that patients with exclusively mast cell-mediated angioedema tend to be a bit older, so at the age of disease onset, so 51 years, and the others are in the 40s, in the mean age. And there's also it seems like there is some association to metabolic disease. So patients with angioedema, recurrent angioedema with or without hives, tend to have a higher chance for hypertension and obesity, independent from the age of the patient. On the other hand, patients with wheals and angioedema with both, it's really a disturbing disease, causing many other, affecting many aspects of life, including maybe also psychiatric disease. So patients become anxious and, can maybe have a risk of anxiety disorders. This is something you also need to consider in your patients with recurrent angioedema. And patients, as always, ask, when is this disease over? It's chronic disease, but usually CSU is self-limiting. And you can see here from this data that about 40% of patients lose their disease within the first year. And there are, of course, a minority of patients that have the disease of chronic spontaneous urticaria for several years. In the mean, it's about 5 to 7 years where CSU is present in patients. And what is actually the reason for having chronic spontaneous urticaria, wheals, and angioedema? So there are two main autoimmune subtypes described. So it's more or less an autoimmune disease where patients either develop autoantibodies against self, so like IL-24, anti-type O, so IgE antibodies against self-antigens, or, which is more rare and even more challenging to treat, is autoimmunity type 2b, where patients develop IgG antibodies against the mast cell, against the mast cell surface, or against IgE, or the Fc epsilon receptor, where IgE is bound on the mast cell. And you can distinguish these two subtypes with some basic clinical workup or diagnostic workup. Look, for example, at the CRP levels. Patients with type 2b, more challenging to treat and often more unresponsive to antihistamines and omalizumab, tend to have higher CRP levels and low IgE, and the autoallergy type has normal IgE and CRP within the range. Well, maybe as one of the last slides, please remember the steps as recommended for the guideline for chronic spontaneous urticaria. And you see here that these 3 subphenotypes of chronic spontaneous urticaria show a distinct response to antihistamines, high dose, and also omalizumab. And interestingly, the group of mast cell-mediated angioedema only without hives responds the best to antihistamines, high dose, and especially to omalizumab. So omalizumab could be really used as a diagnostic, but also therapeutic step to treat mast cell-mediated angioedema. So to sum up and conclude, if you see a patient with recurrent angioedema, in most of the cases, this will be mast cell-mediated because angioedema really often occurs as a symptom in chronic spontaneous urticaria, and therefore you should treat it like chronic spontaneous urticaria in case there are no other hints and signs and symptoms of hereditary angioedema, as Dr. Ankur has outlined in the previous talk. Thank you very much for your attention.
Thank you so much, Dr. Ankur and Dr. Thomas, for this beautiful presentation and giving insights into this very difficult topic. And it was a good, comprehensive presentation from both of you, and it covered all the aspects. And we'd like to have some questions which are there in the chat box. Either of you can take it up. So one question is how to suspect or diagnose type 3 HAE, hereditary angioedema. Dr. Ankur? Or...
So, I mean, of course, you have to have symptoms. So, first thing that we do not call it as type 3 HAE anymore. We call it as normal C1 inhibitor HAE now. So, as Thomas showed in one of the slides, the flow diagram for a diagnostic evaluation of a patient who comes with angioedema. If you have symptoms which look like bradykinin mediated angioedema, and your C4 and C1 inhibitor levels, including C1 inhibitor function, turns out to be normal, and there is a good family history of a similar complaint in any other family member. Now, that is the time when you actually think of type 3 or normal C1 inhibitor HAE. And the diagnosis of normal C1 inhibitor HAE is only and only by doing genetic testing. There is no good biomarkers so far identified for diagnosis of normal C1 inhibitor HAE. So symptoms looking like bradykinin mediated angioedema, no response to antihistamines and to omalizumab, as Thomas showed in one of the cases, a family history present, normal C4, normal C1 inhibitor level and function. That is the time when you should think of normal C1 inhibitor HAE.
Thank you for that. And what is the approximate cost of C1 esterase inhibitors concentration in India?
Okay, so we have 500 unit vials available in India. There are two companies who are manufacturing it. And the cost of one 500 international unit vial comes around 24 to 25,000 per injection. Yeah, so that is the cost at this point of time.
So they require a single dose, or
yes, most often a single dose is sufficient. If used early in the course of the disease, a single dose is mostly sufficient in most cases.
And they have to take even prophylaxis of this or something,
So the requirement for long-term prophylaxis depends. The general rule is that if a patient has at least one episode of angioedema every month, or if they have life-threatening episodes like laryngeal edema, they should be on long-term prophylaxis with any of the drugs that we mentioned. Now, which drug to be used depends on a lot of factors, depends on the age of the patient, the gender of the patient, whether there is a situation like pregnancy. So these are the, then we need to take a call whether we want to start tranexamic acid first or attenuated androgens first. In most cases, we start with tranexamic acid, and then if there is no good response, then we switch them to or add attenuated androgens on top of it.
Okay. And could a brief course of steroids be used to distinguish between the mast cell mediated or the other variety of the bradykinin induced? Is it a good way to distinguish when it is difficult?
So, Thomas, this is, I think, related to your case.
Yeah.
Yeah.
Well, maybe I can say something to this. I think the assessment of response or non-response to acute treatment is sometimes a bit challenging. It really depends on when you start treatment. So when you start initiate on-demand treatment late, you will also see poorer and later response. And in general, my experience in patients that report response to corticosteroids in acute angioedema is very diverse. There are patients that say, well, it helped very, very fast. Within half an hour, they realize there is something happening. But there are also these patients who say, well, it took 4 hours or a day until the swelling resolved. So in case you have a response, a patient tells you something about a positive response, it really helps you to differentiate between mast and non-mast cell-mediated angioedema. But in case of non-response, it cannot tell you actually if this is a mast cell-mediated or not. So it remains difficult. And of course, in general, corticosteroids for prophylactic treatment of angioedema are not recommended, especially for mast cell-mediated angioedema, and it will not help in HAE. Definitely, that's for sure. And I think this is one of the most important things you need to know, that steroids are not described to have show a really good help and response in HAE.
Okay, one more question, Dr. Thomas. How long did you have to give omalizumab like you used in one of your cases? So,
yeah, so usually I use it for half a year. I started and I wait for response at least 3 months, maximum 6 months. And if there's a good response right at the beginning, I start even off-label to taper the dose, of omalizumab to increase maybe the interval of the injection, not every 4 weeks, but every 5 weeks or so, to learn also whether the disease is gone already or not.
Okay. And what is the incidence of mast cell-mediated angioedema without urticaria, like just angioedema without urticaria?
So it's 1 in 100 people in the world, I would say, around about have urticaria, some type of urticaria, and 5 to 10% of these patients have mast cell-mediated angioedema only. But the majority of these patients, let's say 60% of the patients, have both wheals and angioedema. So it's quite common. Yeah.
Okay. And any support from the government for these replacement therapies, Dr. Ankur?
So yes, through this rare disease policy of Government of India, there are 15 centers now across the country that can actually provide support for C1 inhibitor concentrate to patients with HAE. So there are 15 centers so far, which are available across the country. And patients can enroll themselves in one of those centers and they can get support through this policy.
Okay. Yes, so I think
I'm Dr. Dhanesh here, Dr. Sanjana. Yes,
yes,
just
sir.
one point to be made, and Dr. Ankur can tell it actually. Through the support of this Takeda's patient support group, we can do C4 and C1 INH to their support program, which otherwise costs around 4,000 rupees, I think, and that becomes a very difficult. And this is found to be very useful. Dr. Ankur, your point on this.
Yes, sir. So this is the patient support program from Takeda, through which diagnostic tests can be easily accessed. So they are doing C4 and C1 inhibitor levels, and in certain cases they can also do C1 inhibitor function if required. So they are doing it, and they are these are easily readily available, accessible through this patient support program by Takeda. So it's a good way of getting the C4 and C1 inhibitor level done whenever there is a suspected patient with HAE.
And if not, Dr. Ankur, is only one point. If they're not getting only C4, the chances of getting this patient or diagnosis this patient, possibility is how much? If you only C4 when you suspected cases, which is a cheaper test.
So I would say, sir, C4 is a very good screening test in patients with HAE. What happens is, as I showed you in one of the cases, what happens is, sorry, Thomas, you can stop sharing your screen.
Actually, I don't know how to do it.
So okay, somewhere it will be written as stop sharing. Is it?
Yeah, but it isn't actually.
It will be
Okay.
there at the wherever there is Zoom written, sometimes over there.
I am sending you a request. Did you get it? Then maybe you can click on that request. No?
Mm-mm.
It's okay. Fine. No problem. So basically, what were we talking about? Yeah.
C4, C4, sir.
Perfect. So
Only
C4,
C4.
yeah, C4 level is a very good screening test, sir. It's also very important how we interpret C4 level. Sometime C4 level can be low, and then when it is low, it's a very good screening test. C4 is usually never high in patients with HAE, right? If the C4 level is towards the lower limit of normal, like as I showed you in one of the cases, the limit was 14.9, the C4 level was coming around 15.6. Now that itself is a very good clue in your case. If you're clinically suspecting that this is likely to be HAE, and if your C4 comes out to be near lower limit of the normal, in my experience, that also is a very good diagnostic clue in these patients. And then we can always do C1 inhibitor level to confirm the diagnosis. So it's a very good screening test. Like if it is coming out to be towards the upper limit of normal, or if it is coming out to be higher than normal range, and if your suspicion is not very very high, then you can easily treat that patient with antihistamines and also give a trial of omalizumab if they're not responding to antihistamine. And then if they're not responding to omalizumab also, then there may be a point going back to your diagnostic algorithm once again and think if you're really dealing with something else.
Thank you. Thank you.
Thank you. Thank you, Dr. Danesh, for this participation. And thank you, Dr. Ankur and Dr. Thomas, for once again for uh, accepting our invitation in spite of your busy schedules, and also beautifully presenting with great insights, practical insights, especially into this topic. And we would love to incorporate them and try to have a strong suspicion for these cases and diagnose, and would also uh, ask for help whenever needed from you both. So once again, thank each and every one of you who have attended this session, and special thanks to Dr. Neeraj Gupta sir for this initiative under his presidential plan. uh, Thank you so much, one and all. Good night.
Thank you so much.
Nice,
Thank you,
thank you.
Thomas.
Thank
Thank you
you,
so
Ankur. Bye
much.
bye.
Thank you. Okay.